Welcome back to the Nursing Post podcast, All Nursing All the Time with Ashley and Rosa. In this episode, we talk about one of the hottest topics in nursing. And if you're a nurse, you know that's your patient to nurse ratio. Our goal is always to inform and start conversation.
There is an abundance of data and research that shows that when a nurse to patient ratio is lower, outcomes are better. In the United States, we do not have any federal laws that mandate safe patient to nurse ratios. And as of right now, California is the only state that has a law that has a minimal staffing ratio for all hospital units. There's one state.
I have to give them kudos because they obviously saw there was an issue.
Mm-hmm.
And they made the effort to correct it.
So a couple of statistics. I don't think that anybody in the nursing field is going to find this to be surprising. I did not. So in hospitals, a 1-to-8 nurse to patient ratio experiences 5 additional deaths per 1,000 patients compared to a 1-to-4 nurse to patient ratio.
I'm not surprised by that. Because, I'm sure this is including your ICUs, your neonatals, come on.
Mm-hmm. The odds of patient death increases by 7% for each additional patient a nurse takes on at one time.
I'm still not surprised.
Only 20% of nurses in the United States feel staffing levels are safe.
I'm surprised by that because honestly, I wouldn't even think it was 20%. I thought it'd be lower than that.
I wonder how many of that 20% are nurses that are from California.
Okay, point taken.
After ratios were implemented in California, hospital income rose dramatically from $12.5 billion to more than $20.6 billion.
You want to know why? They're not being sued. Less malpractice suits.
Well, and
the hospital, for the doctor,
and state-run Medicare, Medicaid, CMS, yay. They penalize hospitals for readmissions. Just saying.
That's true. Even here in our state.
Yep. Increased nurse staffing is a more cost-effective approach to improve patient care when compared to other interventions.
Imagine that.
Nurse understaffing in hospital ICU increases the risk of infection like pneumonia, which not only lead to injury and death, but also costs the hospital a significant amount of money.
So that kills you.
Yeah. So hospital acquired pressure ulcers alone have been estimated to cost $8.5 billion a year. And healthcare associated infections in the United States have direct medical cost of at least $28.4 billion each year. And they also accounted for an additional $12.4 billion in costs to society from early deaths and loss of productivity. So that's your money right there, is from hospital infections and ulcers.
So the length of stay, urinary tract infections, cases of upper GI bleeds, all increase due to unsafe staffing ratios. Like I said, none of this is really a surprise. Rates of hospital-acquired pneumonia and shock or cardiac arrest, as well as failure to rescue, climbed due to unsafe staffing. Come on, guys, let's break this down like we're in kindergarten. If you're in ICU and you have 8 patients, those 8 patients are already in critical care because they're in the ICU.
Mm-hmm.
So you're asking a nurse to have 8 patients in critical care, something will be missed. There's no way.
On Med-Surg, having 8 patients, to me, that's a lot.
I'm in total agreement. Something will be missed.
Even when you go down to long-term care or skilled care, I think skilled care, most facilities try to do 15 to 20 patients to one nurse. And then for long-term care, it's 30 patients.
But it never happens because they're always short-staffed. I know, I've worked SNF.
Yep.
And when the nurse didn't show up on one of the hallways, that 20 just went to 40.
Yeah. You
And it's
just
called
split it.
skilled nursing
Yep.
for a reason, because you're doing wound care, trachs, you're doing tube feedings, you're doing meds, you're doing treatments, you're doing all of it. So just, I mean, that's super stressful.
Mm-hmm.
And
It really
then
is.
on top of that, you have to document on every single one of those skilled patients.
Yep.
60% of nurses nationally said that they fear retaliation for speaking up about staffing. I think both of us can relate to that.
Mm-hmm.
I'm sure the rest of the nursing world does.
Yep.
Especially when all they want to say is that we're playing cards and compensate us with pizza.
Oh, don't.
Don't go there.
I'm still
Nurse
not over it.
staffing.
I'm still not over it.
She's still in her feelings. Don't feel bad, because I'm still in mine. And maybe that's why nurse staffing turnover is costing healthcare $6.5 million annually, and it poses a risk to patient safety.
It absolutely does. And so this is, like I said, I think most nurses are not going to be terribly surprised by a lot of the statistics and numbers that we pulled there. But what has been proven is when there is better staffing, that patient incidence and mortality decrease.
That's facts.
In my opinion, if you tell me that if you staff better, your nurses are happy, your patients, your incidences will decrease, your mortality will get better. I mean, dang, that seems like it'd be very easy to get everybody on board. Patients are better, nurses are better. Seems like a win-win.
They're making money. It should be like a win-win situation.
So because of that, I'm like, well, what's the argument against this? And it's a very similar argument from multiple people that I've read.
Well, what does it always boil down to?
Money.
Always. The dollars and the cents. Just like you said, money.
So there was an article that I read that stated that the money to pay nurses to keep up with the staffing mandates would likely come from money that would be allocated to things like community outreach projects and mental health access, therefore causing more patient complications, not less. And it would also bring limits to the hospitals, saying that they couldn't accept patients because because they didn't have the staff to care for those patients because of the mandates. So they can't take anybody. So their quote reason to not have reasonable patient to nurse ratios was, in my opinion, infuriating, because I know I haven't worked bedside in quite some time, so it made me mad. So I couldn't imagine the nurses that are currently working bedside, what their thoughts are. But I don't understand why the first thought process was, well, we'll take the money from community outreach projects and we're going to take the money from mental health. My first thought was, well, maybe it's time to get rid of executive bonuses and cut into profits to ensure quality patient care and safe working conditions.
It kills me that these CEOs and, like you said, executives, they're making bank at the end of the year.
Oh, absolutely.
Like they purposely are trying to be under budget so that their check at the end of the year is stacked.
Mm-hmm.
Because if we did put our focus in preventive medicine, such as community outreaches and mental health, there wouldn't be such an uptick in healthcare being needed, especially not the immediate,
right,
or acute.
Mm-hmm.
But I'm not surprised.
And so another thing that I looked at, because of course, you read it a couple of times, but I keep digging because it's the rabbit hole that we go down. I know I sent Rosa probably one too many texts going, oh my gosh, like writing this is making me mad. It's pissing me off. I don't want to.
But it's all important information. I really feel like it is, especially not just for people that are already nurses, but for those that are in nursing school, for those that are out of nursing school. This is really important information. I think it's even important information for patients.
My thing of it is it was not until here recently that I would have ever discouraged anybody from going into the medical field. And I don't say that I would necessarily discourage anybody now, because I think some people just have that pull to want to
Mhm.
help. I know that I do. Like, even if I
Mhm.
don't stay in nursing for the rest of my life, I still want to be helping people in some type of capacity. I know
Absolutely.
that.
Yeah,
You're
I
the same
agree.
way.
I agree wholeheartedly.
But I would say you may need to look into all of your options. There's more to healthcare than nursing. And I think some other aspects are treated better. I think nurses are looked at as disposable, and that's a problem.
Well, we've been told that.
Yes. Well,
We've been told that. I
Mhm.
know I mean, you and I at the place that we worked at together, that
Yes.
has been said to us.
Yes. That is true.
And so that's the mentality.
hmm Absolutely. Everybody's replaceable, I think, is the correct term, to be specific.
Hmm.
So as I kept reading this thought process, I'm like, really? I mean, really, that cannot be the argument. That cannot be the argument. Well, sure enough, it was. There's another guy named Danny, I think this is Chun. He's the spokesperson for Illinois Health and Hospital Association. And in 2019, there was an interview with the Pulse. And this is a couple of quotes. It's a deeply flawed, inflexible, rigid approach to setting staffing levels that does not improve quality, safety, or outcomes, but in fact would adversely affect patients. This is talking about patient to nurse ratios, having mandates. And another thing is it's going to result in longer wait times for patients to get care in emergency department and other units of the hospital. Chun said hospitals would be forced to turn away patients because they'll have to go on an emergency bypass and shut down some of their units because they don't have enough nurses to meet the ratios.
And that's exactly what happened. This is in 2019.
This wasn't,
and that's exactly what happened when the pandemic started. That's exactly what happened. Well, we already had longer wait times in the emergency room here where we live.
Yes.
It's actually in the top 3 busiest emergency rooms in the state of Virginia.
Mm-hmm.
And like, just a little side note, and then I'll move on to get to the point. But the reason that is in our area is because people are using the emergency room as their primary health care because of lack of insurance, amongst other things.
Mm-hmm.
So that's the side note. However, when the pandemic happened, this was already an issue in our city.
Mm-hmm.
So you can imagine you were previously already waiting 8 hours in our local emergency room department. Now add the pandemic to that. So this guy knew in 2019, before the pandemic hit in early 2020, that this was going to happen. It's right there in black and white.
Well, what's frustrating to me, and I read this a couple of times before I put these quotes in, because one of the things that irritates the hell out of me when anybody does it is when they take quotes out of context,
Yes.
to make their point. Like I'm not for that. Like, if you can't find something to back your point, then you're wrong.
Absolutely.
Period. And it needs to be, in my opinion, somewhat recent. Like, this was a couple of years ago. And so I just found this interesting because he pretty much said what I had read in other things as well. And then there was one state, I cannot remember the exact state it was, that actually spent millions of dollars campaigning against nursing ratios because the hospital was that far against
money. But they could have taken that money and hired nurses.
Yeah, but to them, we'll spend a couple million once to get everybody to vote it out, which is what happened. And then now they don't have to worry about it again because everybody spoke. And I'm like, well, yeah, when you're feeding them BS.
Yeah, that's the politics of it.
This is why I say I don't like politics.
But it's everywhere. It's unfortunate.
It absolutely is.
Well, at least in this country, it's everywhere. Like I said, I can't speak to other countries because healthcare is free in a lot of other countries. But there's a downside to that too. That's a whole nother episode. So we're just going to keep ticking along.
Another thing that I found to be super frustrating with this is, like, this Danny Chun guy, he started off as a nurse. The only argument that I heard anybody make, and this was from a nurse, they said the only downside to the ratios is, say that we have somebody, let's use the ER for an example, just because it's an easy in. you have a nurse that, and I think it's like 3 or 4 patients per nurse in the emergency room. If a nurse has 3 patients, say they have a 3-patient mandate, one's in CT, so they don't have their patient because they're off to get CT. Another one is not critically ill because they're using it as their primary care doctor. And then they have another patient that comes in, let's say, I don't know, they have a broken bone and they're waiting on ortho to come down. But really, there's not a lot that the nursing can do from the nursing point. You know, they're just waiting for a consult essentially so they can be sent home to go to an outpatient orthopedic. So at that point, no, that nurse is not busy. She's not busy. Could she safely probably take another patient? Absolutely, probably could, especially if it's a seasoned nurse. I would say very easily a seasoned ER nurse could take on a 4th patient. Absolutely. However, what if one of those people come in, there was a bad motor vehicle accident involving 2 or 3 people in that car? Well, that one nurse cannot care for those 3 people at the same time.
That's true. To me, this is where, nursing judgment, why you have, a unit manager, a director of nursing, or somebody there to make those calls and those decisions. And of course, as a nurse, you have to be able to speak up and say, hey, listen, there's no way that I can take care of that extra patient or those 5 patients or what have you. Like, you have to stand up and say, like, no. Because if not, like I keep saying, at the end of the day, it falls back on you. It doesn't fall back on your unit manager, doesn't fall back on your doctor, doesn't fall back on the facility that you're working in or your organization. It's going to fall back on you. So you have to use your nursing judgment. But, the organization also has to do their due diligence. They also have to provide.
Well, the frustrating part for me is, I want to know how many people go to work and work at 100% capacity every time they're at work. I can tell you it's 0.
Yeah, I agree.
You might have some caveats out there, but I'm going to tell you, even they have off days. So why is it like just this crazy thought process that for this moment in this ER nurse's day, a moment, because this is all ever turning. It's not going to stay like this. Why is it like a terrible thought that she not be crazy busy? Why is that so frowned upon? Why not say, something, she's not that busy. Maybe she can help out another patient or another nurse rather.
Another nurse. Because that I would do that.
Person, and no, I'm not taking on that patient as my patient, but I'm going to help my coworker out.
Exactly. Like I would do that. I'd be like, okay, I'm not busy. Is there anything that you need help with? Like, do you need me to call a doctor for a verbal or, whatever it is? I would be more than willing as a nurse, because that's who I am, to be like, hey, is there anything that you need? Is there anything that I can help you with? Because one, I don't like to be bored. I don't, you know what I mean?
Oh, yeah.
All my ducks are in a row and my patients are fine. Like, I'm going to be going back crap crazy, not having anything to do. So I'm just because of who I am, I'm going to be like, hey, do you need any help? Do you need me to run anything? Or, do you need me to answer any of your call bells? Whatever.
Yeah, there's so many things. So I just feel like it's so crazy that part of these arguments as, well, it would tie nurses' hands that could take on an extra patient, but doesn't give them ability to. So what? That's my response to that. I am all for nurses not having to kill themselves every shift.
We shouldn't have to. That's the point and the problem.
Yep.
Is we shouldn't have to kill ourselves.
Like, could you think about maybe the nurse being able to pee 3 times in her shift?
I can't even imagine. Honest to God, I can't. I'm lucky if I was able to go once.
See, this is
once out of an 8-hour shift, let's say,
This is completely and utterly sad. I was helping my sister. She is moving, right? She looks at me halfway through. She's like, I really got to pee. And I'm like, go pee. And she pauses. She literally pauses. And I was like, why are you holding it? You're home. And she's like, I guess I'm just used to it.
Used to it. because she's a nurse and that's what you
And
do. You know, you're like, I
that
have
shit
to
is
get this
sad.
one thing done. I have to get this next thing done. But you know what that's going to happen? What's going to happen? Me being the former urology nurse knows that that's not good for us. And like all of us in about 20 years are going to be sitting in the urology office being like, I can't empty my bladder all the way. I have urgency and frequency. You know what I'm saying? Like we already know it's not good for us, but then we're put
Yeah.
in positions where it's impossible. We don't get breaks.
No.
In some days, it's hard to even get a lunch, let alone a break.
Yeah, no, I'm not even like advocating for a break. Like that's so far down. Like a lunch and being
A
able to
lunch is
eat.
nice. At least
Yeah.
I'm guaranteed one pee break. You
Right.
know, at least that's a guaranteed one pee break. I mean, there's just so many things that are just fractured and broken. And I don't feel like we should have to kill ourselves, you know. Things make sense. Common sense. Like if you're working with a hospice patient,
Mm-hmm.
like I would not give a nurse more than 2 hospice patients, especially if they're the ones that are having to be the aide, the nurse.
That's a lot
There's,
of care.
yeah, but here they'll give you 1 to 4, 1 to 5,
Yep.
1 to 6. And these are people that are actively like passing, and it just blows my mind.
The other flip side to this is I did look into California a little bit, who, by the way, has not had any issues with having to really turn people away or mental breakdown since making their their mandate for nursing ratios. But
Kudos.
I really feel like, okay, if we were to get ratios, would it make a difference? Like if we were to get a federal mandate, because you have your really sick patients who are 1-to-1, and of course we have long-term cares. In Virginia, your normal staffing for long-term care is 1 to 30.
That's true.
That's your normal staffing. I know a nurse from New York who they were doing 1 to 45 and 1 to 60, and the nurses were going home crying every day, which I was just like, damn, that's rough. Like I
It
knew
is
the
rough.
30, you didn't really sit very much, but that's a lot. In the midst of this whole pandemic, California did waive their ratios. And those nurses took assignments that were bigger than they've had to deal with in over a decade.
I'm not surprised. I think, pretty much during the pandemic, it was, crisis mode. And, not only did ratios go away, but, they waived a lot of requirements for new nurses, new providers, new doctors coming out of school. Like they waived a lot for people to help in this pandemic. I still feel a certain type of way about it, to be honest. Like I see the reason why, and then I'm like, oh my God, that's my worst nightmare. If I was a patient and, they didn't go through all the requirements and regulations that everybody else went through, as a patient, I'd be like, oh my God, I'd be freaking out if I knew that.
Right. Which is, of course,
But
they're
then
not going to close any of that because they don't want to, like, oh, it'll be okay. It'll be okay.
Exactly.
And when you're looking around looking for a seasoned nurse and you realize that you're the seasoned nurse that's there, it's like, oh, shit.
Yeah. You're like, I'm effed. At the end of the day, I'm effed. So when you brought up California, everybody knows that we're based out of Virginia. So I was like, you know what? I'm going to do some more digging. To be honest, I was very disappointed. Our Virginia State Board consists of a membership of 13 people, 7 RNs, 3 LPNs, and then 3 citizens.
Which is a good mix. I think that's good.
One of those registered nurses has to be a nurse practitioner. So there's at least a provider there. But reading along, the nurse is responsible and accountable for making decisions that are based upon educational preparation and experience in nursing. It also said that the nurse shall be held accountable for the quality and quantity of nursing care given to patients by himself or others who are under that nurse's supervision. that's a lot. If you're an RN, you're now responsible for your LPNs.
Mhm.
So, and then if you're the head RN, you're responsible for your RNs and your LPNs. I mean, that's a lot.
It
And
is.
then, of course, you're the one being held accountable. It doesn't say, the facility, the
Mhm.
organization, or anything. The thing that was repulsive is pretty much what you said. No other state other than California had ratios. There's no ratios at all on Virginia board nursing, not for your hospital, not for your SNFs and long-term cares. There's not for your assisted livings, nowhere. So that leaves me questioning, like, who do you go to for advice? I mean, I feel like your board of nursing, it should be where you go to get your answers. The funny thing that I found was specifically in there, it stated that they do not give legal advice.
Nope.
Where the fudge? Where the fudge do you go?
No, I remember reaching out to the board at one point about an issue with a place that I had previously worked and said, there seems to be some unsafe stuff going on here. Who is responsible if there's like an issue? They did respond that they do not give out any legal advice, and that if it wasn't a safe working environment, then I shouldn't work there. That was their answer. Quit, pretty much.
It's sad to me because in our Bill of Rights that we just talked about in the prior episode, what is one of the rights?
Yep.
Is advocating for patient safety. It's just, it was very disappointing. Of course it says in there, to stay in your scope of practice. If you're a nurse or if you're in nursing school, you know exactly what that is. So I'm not going to sit here and read it to you. I can just let you know it's, in our state, Virginia Code 54 .1-3000, and then the thing that really got me was causes for denial and disciplinary action, because let me tell you, there's a long list in there about, what happens. There's not much on there to tell you what to do right, but there's a whole lot on there that tells you what happens when you do something wrong.
Absolutely.
And so it's, number 5 was extremely important enough for me to put in here. And it said practicing in a manner contrary to the standards of ethics, or in such a manner as to make, your practice a danger to the health and welfare of patients or the public. It's just crazy to me.
Right. So like the nurses who would destroy vials of vaccine, no, they didn't hurt any patients, but that would be considered, endangerment
The welfare
to
of the public.
Yeah. So that's kind of how they get those nurses. It's like, no, it's not just patients, it's community, public, all of that is wrapped into that. I think Rose and I have probably been nursing for 13, 14 years. So we have a combined 20 some years of nursing experience. And I think the one thing that we have learned was that you are the only person that's going to advocate for you.
Bottom line, end of the day.
And we have very different backgrounds, which I think helps. But like Rosa has said the past couple episodes, it's going to boil down to your nurse's judgment. And you're the one that's going to have to answer for yourself. And if you're taking unsafe ratios, it's a big question that you need to be having with your employers, because if something goes wrong, and again, we've said it before, we kind of live in a little sue happy country, it's going to be you, and there's not an entity that's going to help back you.
I can say, just like there's insurance for physicians for malpractice suits, it's available to nurses, but to be honest, I don't really know any nurses that have it. I'm not saying that you shouldn't get it. I think at this point, and everybody should get it. Don't know how expensive it is. Maybe that's like a whole nother episode we can do, but
if that's something people would like to know more about, absolutely.
Yeah, I mean, at this point, doctors are being sued left and right. Facilities are being sued left and right. We do live in America, the world of suing people for sneezing wrong. And it's definitely something that nurses should consider. I mean, it's only one more thing that can help you and not hurt you.
Absolutely. Well, thank you for listening to this episode. You can visit us at thenursingpostpodcast.com to get a link to any of the references from today's podcast. Share your thoughts if you guys would like to have us do a episode on malpractice insurance for nurses. We're happy to do so. Just let us know. And thanks again for listening to the Nursing Post.
See if Pat can fix your